Good evening. We will be starting from mouthwashes, page number 58 from therapeutic guidelines. Now, this topic covers practical information on using mouthwashes and other topical formulations in dentistry. Let me select this tool. For comprehensive drug information, including precautions, contraindications, adverse effects, and drug interactions, we would have to consult appropriate drug information resource. And if prescribing a mouthwash or another topical formulation, consider the benefit-harm profile of the drug in the individual patient. And this requires knowledge of the patient's medical history, concomitant medications, including prescriptions, over-the-counter, and complementary medicines. Then mouthwashes used in dentistry. Antiseptic mouthwashes decrease the number of microorganisms in the oral cavity and can be used for periodontal disease, dental caries, and pre- and post-procedural mouth rinsing. So there are 3 uses of mouthwashes in where they decrease bacteria in 3 different scenarios. So this is periodontal disease, dental caries, and pre- and post-procedural mouth rinsing. Then fluoride mouthwashes have significant benefits in patients at high risk of dental caries, but should only be used on recommendation of a dentist. Anti-inflammatory and analgesic mouthwashes like benzidamine provide symptomatic relief. So benzidamine is a different class of a mouthwash, which is for symptomatic relief of inflammatory oral mucosal diseases. Then we have lubricating mouthwashes. These are artificial salivary products, sodium bicarbonate, which can provide temporary symptomatic relief of dry mouth. Then we have alcohol-containing mouthwashes, which may be associated with oral cancer and should be avoided if possible. In addition, patients with oral mucosal diseases and dry mouth should avoid alcohol-containing mouthwashes because they profound drying of the oral mucosa. So in patients with oral mucosal disease or dry mouth patients should avoid alcohol-containing mouthwashes. And the commonest example of alcohol-containing mouthwashes, Listerine. Then we have topical antiseptics for intraoral use. Now, antiseptic mouthwashes decrease the number of microorganisms in the oral cavity. Antibiotic mouthwashes can reduce plaque formation, but do not reduce existing plaque, which is must be removed with mechanical cleaning. So mechanical cleaning is a must. These are only as adjuncts in reduction the number of microorganisms. Antiseptic mouthwash is not required as part of standard oral hygiene routine. So it is a strong word here, not required as a part of standard oral hygiene regime. Only brushing and flossing is sufficient. The use of antiseptic mouthwashes in periodontal disease is controversial. They are only effective against supragingival plaque and are not effective beyond the gingival crevice or periodontal pocket. Now, patients should be informed that the principal treatment for chronic periodontal disease is professional intervention with debridement of involved teeth and meticulous oral hygiene. So, it is all the antibiotics per se are just the adjunct, and patients should be informed of the chronic periodontal disease goes away with the debridement of the involved teeth, that is scaling and prophylaxis. Although they are not appropriate as the sole treatment for periodontal disease, they can be beneficial in some circumstances, like short-term use in patients with gingivitis or necrotizing gingivitis, when inflammation restricts the normal toothbrushing. Then we have chlorhexidine mouthwash, the major mouthwash recommended as per ADC exams and as per the normal. Whenever we are prescribing mouthwash, this is the first line of mouthwash we would think. Now, this is bactericidal and fungicidal and has activity against some viruses. Chlorhexidine adsorbs onto the oral surfaces, so is effective over a prolonged period. It prevents plaque formation on a clean tooth surface, but does not produce pre-existing plaque. It does not reduce pre-existing plaque. So, pre-existing plaque can only go by scaling and prophylaxis, manual debridement. Intraoral chlorhexidine formulations include mouthwash, which is chlorhexidine gluconate in concentrations of two major concentrations will be used throughout 0.12% and 0.2%. And then gel and a slow release formulation for local delivery into the periodontal pockets. It was previously thought that chlorhexidine mouthwash was inactivated by the detergent sodium lauryl sulfate used in standard toothpaste. However, research has shown that this is not the case. Although it is unlikely that there is an interaction between sodium lauryl sulfate and chlorhexidine gel, further evidence is required to confirm this. Then we have chlorhexidine can cause skin reactions. It can irritate mucosal surfaces and interrupt wound healing. So it has the irritation potential in the mucosal surfaces also. Intraoral use can produce burning sensation, altered taste, and increased calculus formation. It can also cause brown discoloration of the teeth. So chlorhexidine can cause discoloration of the teeth and tongue, buccal cavity, margins of the dental restorations. Extrinsic staining is not permanent and can be professionally removed from the teeth. Chlorhexidine is usually recommended for short periods of up to 2 weeks to minimize the adverse effects. It has been reported, chlorhexidine allergy has been reported, sometimes so severe as to be life-threatening. If a patient reports a history of allergy to chlorhexidine, it must be avoided via all routes of administration, including topical application. Then next drug or next topical mouthwash we would read is hydrogen peroxide. Topical hydrogen peroxide has antiseptic properties. Short-term use of low concentration hydrogen peroxide mouthwash, which is 1.5%, does not adversely affect hard or soft tissues of the mouth. However, higher concentration, which is 30 to 35%, acts as tooth bleaching products. So hydrogen peroxide, as we know, it oxidizes the discoloration and is an effective bleaching product. And at this concentration, it can cause mucosal burns. So when we are doing hydrogen peroxide bleaching, it is strictly under rubber dam and strict isolation. Now, reversible hypertrophy of the papillae of the tongue can occur with continuous use of the hydrogen peroxide mouthwash. So hypertrophy of the papillae is the disadvantage side effect of it. Other topical antiseptics. One is cetylpyridinium chloride. It's a quaternary ammonium compound with surfactant, detergent, and antibacterial properties. Intraoral formulations include mouthwash, gargle, and lozenges. Some formulations combine cetylpyridinium chloride with a local anesthetic or an anti-inflammatory. Povidone iodine has antibacterial, antifungal, and antiviral properties. Intraoral formulations include mouthwash and gargle. Povidone iodine can cause irritation of the skin and mucous membranes. So it Iodine can also cause irritation of the skin and the mucous membranes. It is absorbed through damaged skin, so application over a large area of the broken skin is not recommended. Povidone iodine should not be used during pregnancy or lactation because it causes hypothyroidism in the neonate. This should not be used in pregnancy or lactation, and it would lead to hypothyroidism in the neonate. And important, you should form an important memory of this part, not to prescribe povidone iodine mouthwashes in pregnant women. Mouthwashes containing essential oils like eucalyptol, menthol, thymol, methyl salicylate have been found to have antiseptic properties and reduce plaque formation, but there is limited independent evidence of the benefit. Triclosan is not recommended. So these were all mouthwashes which were having antibacterial properties. The next topical drug which we will study is topical intraoral benzidamine, which is a NSAID. Benzidamine is an NSAID with analgesic properties. It is used for temporary relief of painful inflammatory oral mucosal conditions. Benzidamine formulations include mouthwash, intraoral gel, and spray in the concentrations of 0.5 to 1%. Some formulations combine benzidamine with an antiseptic. Local adverse reactions of benzidamine, such as numbness, because it's a pain killer, so it would make the mucosal area numb. It may produce burning, it may produce erythema or rash. They are some of the side effects which have been reported, and systemic adverse reactions are uncommon. Then we have topical remineralizing agents. One is fluoride. Now, fluoride significantly reduces the incidence of dental caries. Topically applied fluoride promotes enamel remineralization through the formation of fluoride-containing apatites, example, hydroxyapatite, fluorhydroxyapatite and fluorapatite. So fluoride, we know that it remineralizes hydroxyapatite of enamel into fluorapatite, which are more resistant to future acid challenge than the carbonated hydroxyapatite of the normal tooth enamel. Now, fluoridines have an antimicrobial effect at very high concentrations. Formulations with a low pH, example, acidulated phosphate fluoride, also have some antimicrobial activity. Fluoride formulations include toothpaste, mouthwash, gel, foam, and varnish. The recommended concentration of fluoride toothpaste varies according to age and risk of dental caries. And we would have more information on dental caries when we are reading further. Then fluoride is only basically used for the dental caries. No other purpose of giving fluoride topical products intraorally. Then CPP ACP, another product which is contains, it is named as casein phosphopeptide amorphous calcium phosphate. It contains bioavailable calcium and phosphate ions, which combine with fluoride to promote enamel remineralization. CPP ACP formulations include sugar-free chewing gum, paste, and varnish, some of which also contain fluoride. Avoid CPP ACP in patients with allergies to milk proteins. And for more information, we would further follow it up in dental caries. So this was the information, and these were all topical products used in dentistry. All the mouthwashes, which are reducing the microbiota, they act as adjunct. The fluoride mouthwashes, the benzidamine mouthwash, and hydrogen peroxide mouthwash. Then we have CPP ACP, topical chewing gum, paste, and varnish. Any doubts so far? Okay, that completes our pharmacology core from therapeutic guidelines, and we would proceed with dental caries. So we will begin with the dental caries part of therapeutic guidelines from page number 63. So I want to highlight important question asked here, which is chlorhexidine role in increasing the calculus formation. So we might have a pre-assumption that chlorhexidine reduces the calculus formation. However, it is not. It gets absorbed onto the tooth surface. Here it is mentioned clearly. And this absorption onto the surface acts as the foci for the nidus formation for calculus. So it hastens calculus formation. The effect antimicrobial it does is reduces the flora, that is reduces the microbiota per se, but calcification is hastened by chlorhexidine. That's why they say to minimize adverse effects, all the staining, calculus formation, burning sensation, it should be only prescribed for 2 weeks. Another important reiteration of a concept here in CPP-ACP formulation, it is avoided in patients with allergies to milk protein. So if a child, which is a high caries risk child, we have to ask in history if the child is allergic to milk or not, milk and milk products. If yes, CPP-ACP cannot be prescribed. And CPP-ACP commercial name available is tooth mousse. Tooth mousse, again of 2 variety. One is tooth mousse normal, like just the name tooth mousse, which is containing CPP-ACP. And one is tooth mousse plus, which contains CPP-ACP and fluoride. So we have these important information about this. Moreover, we will read about CPP-ACP and fluoride in the next chapter onwards, which is dental caries, which we will do in the next session. All right. I'll end this session and resume with the next.